Hello, everybody. Welcome to Pre-Health Shadowing. We are an international student-led, women-led, minority-led nonprofit for medical advancement. We do have closed captions available to accommodate students of all needs and abilities. So if you have any ideas on how we can be more accessible, please feel free to email us at info@prehealthshadowing.com. And do make sure to keep us as a contact to keep us out of your spam and join our email list to never miss a session. And if you'd like to stay in the loop, make sure to follow our Instagram and TikTok at Pre-Health Shadowing. We do host students from all over the world, so drop in the chat where you're calling from today. If you are interested in being a part of Pre-Health Shadowing, you can become either a student volunteer or a team member through our website. And we also do have opportunities to join our leadership team, which are all 100% remote. These are just a couple of the opportunities we have available currently. And if you're a high school student, please join our high school training program, or HTP, which is offering leadership and healthcare education for pre-college learners. And if you can, please donate to help our program stay free and accessible to everyone, as we do run solely off of the time and donation of our volunteers. And do type your questions in the chat so our co-host will ask them during the end of the Q&A session. And make sure that you are taking good notes, as our post-shadowing assessment will be available to take to earn a digital certificate verifying your hours on our professionals course page at prehealthshadowing.com. And if you can, please turn your cameras on to help this stay as true to a shadowing experience as we can. We know it's not possible, but a little face-to-face goes a long way. And now onto your professional to give their presentation.
Okay, so you can see me, I think. And look at my presentation here. Oh no, you need to see the whole thing. Do that. There you go. All right. Can you see my whole presentation?
Yes, perfect.
Okay, great. Well, thank you for inviting me. I'm happy to be a part of this conversation. I see there are a total of five or six of us on tonight. Is that right? Or are there more people somewhere else, or is this everybody?
I think this is everybody for now. We definitely do have more people join in later on.
Great. So I thought I would just spend the next half hour or so, 40 minutes, saying a little bit about my background, what I've been doing, what I did to get to where I am. In full disclosure, I feel like I'm still in the middle of my career, if not even early in my career, because I feel like I'm always still learning. And that's the best part about, at least for me, being in medicine and in health. Um, and I'll try to focus a lot more, I think, on what got me to where I am, and a little bit about the problems that I think are really important for us to think about in society, and then hope that will motivate some questions from all of you, because I don't want to talk for the whole hour and a half. So first of all, this is the University of Chicago. This is my alma mater. This is where I went to college and medical school, and later, as you'll learn, to work in my first faculty job. And it really is sort of they say alma mater means mother soul, and it really is. The University of Chicago is a relatively small undergraduate school. It's a much larger graduate population on the south side of Chicago. And it's really where I earned my intellectual independence. But as you'll see, a lot of my career has been what I call a series of unplanned fortune. So the first unplanned fortune was that when I went to the University of Chicago, it was actually by accident, because I had initially accepted to go to the University of Illinois in Urbana-Champaign, which is the large state school in the state of Illinois. And I learned about them and got early admission and so forth, and basically had a roommate and a major and all that picked out by May, I think, or April of my senior year in high school. And then I learned after accepting and all of that at the University of Illinois that I'd gotten a full ride scholarship to the University of Chicago. When I chose to go to University of Illinois, it was as a biomedical engineering major. I was very interested in numbers and mechanics and physics, and I wanted to find a way to connect that to biological systems. And I honestly didn't have much of an interest in healthcare or in medicine at the time. I come from a background, my parents are immigrants to the United States. I'm first generation, and a lot of my relatives are nurses, but most of them were nurses in the Philippines, and it wasn't until later on when I was older that many of the nurses who I knew in my family came to the States and became nurses here. So being in healthcare wasn't really a big emphasis in my family. So I was one of the first people to go into healthcare and into medicine. And so it really didn't feel like it was something that was accessible to me. And now looking back, I wish I'd thought differently about it, although in the end, things worked out just fine. But when I got to the University of Chicago, it was under a full ride scholarship. I was very fortunate to have that opportunity to come to Chicago. The only limitation on my scholarship, though, was that I had to graduate within 4 years, which is pretty typical. Except that when I got to the University of Chicago, I didn't actually read the college handbook, and I thought that I was still going to be able to major in biomedical engineering. And when I had my first meeting with my college counselor, he said, "Well, we don't have an engineering program here." So shame on me. I didn't really do the homework to figure out what was available to me. And so I picked biology as my first major because it was the thing that was closest, at least so I thought. And it didn't take very long for me to realize that just straight biology was not my calling. It was very research oriented at the University of Chicago, and that really wasn't my thing at the time. So I switched my majors several times. I applied to a major that's now called History, Philosophy, and the Social Sciences of Medicine, and I was rejected from that program. And so that was a major setback. And so by the time junior year or third year came around, I really didn't have a major that I was in love with. And I needed to pick something quickly because, as I said earlier, my 4 year scholarship would run out at the end of 1996. And so I needed to figure something out pretty quick. So I ended up picking environmental studies. And back then it was very new. This was in 1994, 1995. And environmental sciences was a pretty early field. And it's obviously grown a lot in the whatever 30 years since then. But back then it was not a really big thing. And it was my first exposure to public health. I was very interested in pollution and how that caused, lung cancer, pulmonary disease. I was very interested in how DNA replication and disorders in DNA replication caused cancer and how pollution affected the way DNA replication and things happening on a chromosomal level. And so that's really when I got interested in medicine. So I applied to medical school, ended up going to the University of Chicago also for medical school right out of college. And same sort of thing. I was very, interested in the human side, the public health side, and not as much interested in the bench research side. But another thing that happened, fortunately for me in my first year of medical school, was that I applied to be a National Health Service Corps scholar. And the National Health Service Corps Scholar Program is a federal program that pays for medical school. So I had essentially a full ride of scholarship through medical school. But in exchange for that, for every year that I accepted scholarship from the government for medical school, I owed 1 year of service in a medically underserved area upon graduation from residency. So I knew all along that I would be in one of the primary care specialties. So long story short, I graduated from medical school in 2001. So if you're doing the math, it took 5 years because I took 1 year off during medical school to go to public health school. Partly because I wasn't sure what I was interested in terms of choosing a medical specialty. And number two, because I really wanted to learn more about this interest that I had in public health, because it was really what got me into medicine. And I didn't really see a lot of the public health, at least at my medical school at the time. So I went to public health school during medical school and ended up deciding that family medicine was my calling because, it is and it was the only medical specialty which was focused on primary care, um, the community, doing OB, doing pediatrics, and doing adult medicine. And I thought that I might have some interest in doing more health policy work down the line. And so I thought family medicine was the closest fit for me. So I found my way to this city. This city is San Francisco, California, and the hospital where I trained is right there in the middle. As you can see in the distance is the San Francisco Bay and the Bay Bridge. And I moved to San Francisco by myself. First time I left Chicago in my life, and really got to learn what it was like to serve in an underserved area. Where I trained at San Francisco is the San Francisco General Hospital, which is the level one trauma center for the city of San Francisco. And it really is the ground zero, if you will, for underserved medicine, if you know, in the Bay Area, certainly, if not really across the West Coast. There are very few hospitals like San Francisco General on the West Coast. You know, you could think of Harborview in Seattle and Harbor UCLA down in LA. But San Francisco General Hospital became my clinical home. And it became my advocacy home because this is where I learned the craft of being a physician. I cultivated my interest in the underserved in San Francisco. I really began to appreciate the impact of poverty, of racism, of all of the social factors that matter so much more in our patients' lives than things that are traditionally thought of as being important in medicine. And so I stuck around. I did an additional year as a chief resident. So I was there for 4 years. And for my first job, I moved back to Chicago. And so I went back to Chicago, and as part of my National Health Service Corps scholarship, as I mentioned before, I worked for 4 years in community health centers on the south side of Chicago. So these are primary care clinics. I was seeing patients full time, and seeing people in the outpatient setting. I did not do any hospital work. And then I was also affiliated with the University of Chicago Department of Family Medicine. We started the department in 2004 and 5. I was one of the first faculty members in that department. Now it's a huge department. But I got to be a part of what was called then the Urban Health Initiative. The Urban Health Initiative is an initiative to bridge academic medicine and the community on the south side of Chicago, which was stricken with very heavy concentrations of poverty and violence and a long history of being disenfranchised from the medical system. And my boss at the time was someone everybody knows, Michelle Obama. So Michelle Obama led the Urban Health Initiative. And I remember very distinctly on the Friday before Martin Luther King Day, I think it would have been 2003 or 4. No, sorry, it would have been 2006 or 7. Michelle, I remember telling me that we would have to put the Urban Health Initiative on hold because her husband was about to make a big announcement that Monday. Well, obviously, the big announcement was that her husband, Barack Obama, was going to run for president. And so that was effectively going to extinguish the Urban Health Initiative if he won. And obviously, he won. So Michelle and Barack moved to Washington, and things really kind of petered out in Chicago. And around the same time is when my then wife got recruited to Rochester, New York. And so we relocated to this city in upstate New York. And so Rochester, New York is a town of about 400,000 people. The county, the area at large has about 750,000 people. And this is where I live now. When I moved to Rochester, New York, I was the medical director of an outpatient family medicine clinic and got to work with residents and students. And I realized that when I was trying to run a clinic, I didn't know everything I needed to know. And so I went back to business school. So in addition to my master's in public health and my medical degree, I also have a master's in business administration. So that was what really prepared me to be both the medical director as well as to lead the county health department, which is what I had been doing until just last week. Last week, I stepped down from my role as commissioner of public health, which is the local health officer for the county of Monroe. But I spent 8 years doing that job, and very rewarding, and was very grateful that I had the both clinical experience and the business experience to get me to that point. So I'm going to pause. Are there any questions about anything? Because I have some content that I want to share with you, and perhaps that'll stimulate some questions, but I wanted to give some space if there are any questions now. Okay, I will keep going. So I want to talk a little bit about health and health outcomes and where we are. And I want you all to start thinking about health and what your potential role in health and healthcare could be. I want to say a little bit about life expectancy in the United States. Well, I'll spend a little bit of time talking about COVID and what we can learn about COVID. But then I really want to focus on what we can do, thinking between health and medicine as well as public health in the community. Because as I hope you'll see, I don't think the ways that we improve health are necessarily only through healthcare. Healthcare, as you know, is traditional settings like hospitals and clinics and nursing homes, very, very expensive settings. And the reality is that, we are the most expensive healthcare system on the planet, largely because we have the best hospitals on the planet, but we don't have the best health in the planet. And there's a big disconnect there. And so I want you to really be thinking about what's wrong with our system. There's a lot of things that are right about our system, but when you think about what we are able to achieve with the amount of investment that we have, we really ought to be doing a lot better. And so to give you some examples, what I'm showing to you here is life expectancy in the United States. And life expectancy in the United States is that green line there at the bottom. And the comparable countries in the world is the blue line on top. And if you can see even there, the faint lines around the blue line are all of the countries that make up the average that is shown in the blue line. So you probably can't read it, it's too small, but the very beginning of the graph is 1980. And there you'll see that our life expectancy in the United States was really in the middle of the pack with the rest of the world. But in the 40 years since then, the rest of the world's life expectancy has gone up more dramatically than ours in the United States. So we've increased, modestly, while the rest of the world has increased quite a bit. And if you can see all those gray lines by 2016, none of those gray lines are near us. We are decidedly below the average, much below the average compared to comparable counties or countries. And then, so there's that separation that you see there in the last 35 years. The other feature that I want to point out is the huge decline in life expectancy that the whole world saw in 2020. And that, of course, is due to the pandemic, the COVID pandemic. A couple features about that. Number one is that the decline in the United States is much steeper in slope than the decline in the rest of the world. And number two, the rest of the world has already begun to reverse that decline, whereas in the United States, we haven't yet reversed the decline in life expectancy that came from COVID. Now, to be fair, we started seeing declines in life expectancy before COVID, and most of the reason for that is the overdose crisis, which we'll talk about at the end. But the overdose epidemic is a problem that is uniquely American. The rest of the world does not have an opioid overdose epidemic like we do. And so you can see little dips in our life expectancy there in 2015 and 16, but certainly not as big as what we had during the COVID pandemic. So just to pause a little bit on what life expectancy means. So what I'm showing to you here is life expectancy between men and women, males and females, between the United States and the rest of the world. And for the first time in that purple line, life expectancy for women in the United States is less than the life expectancy for men around the world. Women live longer than men in almost every industrialized nation, but for the first time, men in around the world live longer than women do in the United States. So just to give you a sense of what that means. So life expectancy, just to back up, is defined as the number of years a person is expected to live as of the day they're born into a particular community. So if life expectancy in a particular community is 70, then a person who is born in that community on the day that they're born, they're expected to live 70 years. Now, we know a lot of people tend to die more in later years in life, 60s and 70s. So if there's an increase in cancer, you'll see people dying at 60 and maybe 50 more. Okay, so that's not going to have as much of an impact on life expectancy as if you saw a lot of people dying in their 30s and 40s. So you just think about it mathematically. In order to drive life expectancy down, you have to have a large number of people dying in their earlier years. So in the United States, the last time life expectancy dropped before the COVID pandemic and before recent years was in the mid 80s due to HIV and AIDS. That was when a lot of people, men typically, died in their 30s and 40s because we didn't have ways to treat HIV at the time, and we didn't even understand the transmission of HIV in the beginning. Before HIV, the time before that when we saw a decline in life expectancy was World War II. And the time before that was World War I. So it takes a lot of people dying in their younger years to drive life expectancy down. And to see that that's happening right before our eyes, and we're in the middle of a skid in life expectancy as we speak, I think should give everybody some pause. So to put that in perspective, we're the most expensive healthcare system on the planet. So the green line at the top is healthcare expenditures per capita in the United States is that long, tall green bar, about $13,000 per capita is spent on healthcare in the United States. Now, that's not all of health, but healthcare is the vast majority, as you'll see in the next slide, of what funds health. In blue, there is the comparable countries across the world. Our total budget is $4.2 trillion for health. And the majority of those services, as you'll see there, the blue hospital care piece of the pie, all the way around to the green prescription drugs of the pie, is actual health care. And then the rest of it is administrative. You've got health insurance, government administration, other personal health care is a small piece of it. And then government public health there is in that sort of yellow bucket. It's about 4.4%. Now, government public health, like health departments, like the one that I came from, is not the only thing that public health can do, but it's a relatively small piece of the total $4.2 trillion healthcare budget. And so you might ask yourself, why is it that we don't get the level of outcomes, that we don't have the life expectancy that other countries do, even though we spend so much money on healthcare and on health for that matter? And the reason for that is because we don't have a very good primary care system. So these are studies that were published in the 1980s and 1990s. And on this one, what I'm showing to you here are countries that have higher primary care quality have lower spending. Okay. So the more, say it the other way, the more you spend, it doesn't necessarily mean you have better care. So if you look at the y-axis there, it's primary care score, and that's how well a system scores with regard to various primary care outcomes. And so the higher the score, the better you are in terms of primary care. So the UK, Denmark, Finland, Netherlands, Australia is all AUS. Those are Canada. Those are the countries that are high in primary care. And as you can see, they spend less per capita on healthcare. Okay. So the United States is the outlier. We spend a lot more money per capita on healthcare. This slide is 20 years old, but we have, have low primary care. So the assumption here is that the more you spend, the better your primary care system is, the more you'll be able to save money. So let's look at it the other way. Let's look at the impact on life expectancy when you have more primary care. So this is a study looking at states in the United States and the number of primary care physicians they have per capita. And on the x-axis is, toward the right is more primary care physicians per capita, and toward the left is fewer. And on the y-axis is life expectancy. So you can see that the more primary care physicians per capita, the greater the life expectancy in general. So Hawaii is up there, Minnesota, Washington, Connecticut, Massachusetts, California. Those are the states that have more primary care doctors per capita, and they tend to have the highest life expectancies among states in the United States. Maryland is an outlier. They have a lot of doctors because they have a lot of universities there, but they also have Baltimore, which has lower life expectancy for a variety of other reasons that we'll talk about. So in this slide, I want to remind you that whenever you or however you go into health or healthcare, to remember that we're all a product of our environment. What I'm showing to you here is a relatively old slide now from originally in 2001, I think, where they look at the ecology of healthcare. And if you look on any given day in the United States, and they came up with this through a variety of different surveys and studies and so forth. But if you have 1,000 people, pick 1,000 people anywhere in the United States, and you pause and they pause and think of what might be wrong or something potentially wrong with their health. They might have a symptom like a cough or a cold or an ache or a pain or a mental health concern or what have you. On any given day, 80% of that 1,000 people, so 800 people, will have some kind of symptom that bothers them. About 32% of them, 320 of them, will actually consider, just think about seeing medical care, whether it's a doctor, urgent care, hospital, whatever. 217 of them will visit an office, and 113 of them will visit a primary care office. 65 will go to a complementary alternative medical provider. 21 will go to a hospital outpatient clinic, and so on. And then maybe less than one of that 1,000 people will find themselves in an academic medical center. I say all that to say academic medical centers is where almost all of the future doctors in this country train. Let me say it again. Almost all, not all, but almost all future doctors, so medical students, are training in some kind of an academic medical center or academic community hospital. And the vast majority of people who say that they're sick in some way will never find their way to either of those places. So our medical education is heavily skewed to the kinds of people that find themselves in higher level cares, settings of care, like hospitals and medical centers. So, as you think about what you think you understand of medicine, I guess my advice would be make sure that you're looking at it from multiple perspectives. Think about looking at health and illness from a community's perspective. Think about looking at it from an office perspective. Think about looking at it from the standpoint of a church or a pharmacy or a dentist's office or a school. But don't just think about health or wellness or illness or treatment solely from the eyes of what you see in the most predominant setting of training, which is a medical center or a hospital. So when you add all that up, why aren't more primary care doctors going into, why aren't we having more people go into primary care? The reality is that if we really want to improve health, we can't just do it on the backs of primary care physicians alone. So what I'm showing to you here is the results of the annual match process, which is the process that selects the next generation or the next cohort of family medicine residents. And in any given year, the number of people that we graduate from medical school into family medicine residencies, it barely keeps up with the number of people who are leaving the specialty because of age or retirement or whatever. So, we have a barely growing, even though this map shows that there's a huge increase, relatively speaking, in the number of primary care doctors, it's not keeping up with the increase in demand for primary care. So in the first line there in 2010, so roughly 14 years ago, there was a supply-demand mismatch for primary care. And that supply-demand mismatch grew in the same years that we had the increase in primary care physicians going into practice. So clearly, family medicine doctors and doctors in general are not going to be enough. And so when people say, well, what's the solution to this? The solution is complicated, but I don't think the solution is adding more doctors. And the reason why I don't think just adding more doctors is the solution is because, first of all, it's not what we see in other countries. Even though they have more primary care doctors per capita, the thing that makes health better is typically all of the policies, the social policies that wrap around people before they need healthcare. So prevention and all the other social things that contribute to health and wellness that are cheaper to provide. Obviously, prevention is the cheapest thing of all, because if you can prevent somebody from having cancer, it's a lot cheaper and frankly preferable than having to treat it with chemotherapy and all the things that go into cancer treatment. To give you another example, in many countries in Europe, it is expected and customary for people to have 1 year of paternal or parental leave after having a child. 1 year. And in the United States, you'd be very lucky to find anybody who can take off more than 2 or 3 months sometimes after having a baby. So if you think about, what they're able to do in other countries with that 1 year, we're trying to do the same thing while the parents are working and the child is in daycare or some other such thing, which ends up costing money on society because we all have to pay for daycare. Whereas if you are a parent staying home with your child, you probably don't have to pay for as much daycare, and you have a better experience because you're able to bond with your child because they're with you essentially all day. So that just to give you an example of things that we might want to do in the United States to try to improve healthcare. So because I'm from New York and I'm from Monroe County in New York, I'm going to give you some numbers that pertain to Monroe County, New York. What I'm showing to you here is just age-adjusted total mortality. So, this is the backside of life expectancy. It's how healthy is Monroe County. And Monroe County is in the top half in terms of mortality rate in the state of New York, which is good. But when you look at the mortality rate, if you think of your statistics, rates like this are typically averages, right? You take everybody divided by the total number and you get an average. But I think in health and in public health, I think we need to think a little bit more deeply about these averages, because what actually matters more is not than the average, is the distribution of these outcomes. So to give you a sense, right here in Monroe County, when you look at life expectancy in Monroe County, there's a huge disparity in life expectancy right here in this county in upstate New York. To give you an example, 14534, which is a zip code not far from where I live, the life expectancy there is over 80 years. And then when you go to the inner city of Rochester, New York, the life expectancy is under 70 years. So that's a 10-year difference in life expectancy right here in Monroe County. To give you a sense of what a 10-year difference in life expectancy is, the life expectancy in Japan is roughly 80 years. And the life expectancy in many developing nations is what you see around 70 years. If that zip code was a country on the map, it would rank, I think, 130th in the world, whereas 14534, analogous to Japan, would be like third or fourth in the world in terms of life expectancy. And so although our average might be good overall in Monroe County, the disparity in care between these two zip codes I find to be unacceptable. We shouldn't have this level of difference right here in one county in zip codes that are separated by 4 miles. So why is life expectancy so disparate in Monroe County? Well, a long story short is that the things that impact life expectancy don't impact our population in an equitable way. So the conditions that lead to premature mortality disproportionately impact those who are poor or marginalized. So to give you a sense of what caused life expectancy to drop overall in Monroe County since 2013, drug overdoses, suicide, unintentional injuries make up 90% of what led to that decrease in life expectancy here. And those conditions disproportionately impact people of color, people with limited resources, and people who are struggling through homelessness, which tends to be the case in the zip code that I showed you in the inner city of Rochester, as opposed to the suburb, where you don't see anywhere near that degree of homelessness or people of color or poverty. When you look at the 4 years, the 3 years between 2019 and 2021, the reasons for the decline in life expectancy are, again, COVID-19, drug overdoses, and homicides, typically gun homicide. Again, those are things that happen disproportionately more in our city as compared to the suburbs. So that is why we need to think about health disparities, because there should be no reason to see such a difference in life expectancy when you look at two populations that are situated so close to one another in the same county. So to make a long story short, this is really what we need in our health system. Population health improvement. So population health is defined not just as public health, because public health is defined as the health of a whole population, but population health looks at disparities in health, which is what I was trying to show you with that previous slide. So not just looking at the average of an outcome, but thinking about the distribution of those outcomes across a population and thinking about why those disparities exist, and in general, why those disparities are unacceptable. Number two, in all communities, those that do well in terms of outcomes especially, there's a high degree of community engagement in helping to define the needs of that population. So you have a lot of agencies, a lot of individuals, a lot of schools and churches and other agencies that are involved in health. And it's not just, hospitals and clinics that are driving the boat when it comes to, delivering health. You've got to have aligned leadership at all levels of government as well as the nonprofit sector. There has to be a way to sustain the funding for all of those things, because if all of those things is just on grants that will eventually end, there's no way to sustain progress. The best way to sustain progress is to have consistent funding. And in most communities, the way to have consistent funding is through the tax base. And so I know that taxes are controversial sometimes, but when you look at communities that have a higher standard of living, quality of life, longer life expectancy, they do spend more on taxes. But what I'll say to that is that in the United States, if we don't spend it on taxes, we spend it in other things. in terms of increases in violence, increases in homelessness, increases in all the other things that end up costing us money in the end anyway. So if you're not paying for it up front, you're paying for it on the back end. And it's always better to prevent than to treat. And then finally, using data. And the area of health informatics is a budding field in health and in public health. There's a saying that I often say is that you can't improve what you can't measure. And if you can't measure something, you don't know what you're dealing with. And so if you can't define a problem numerically, or at least in terms of data, it's very hard to know if you're making any progress. And so something I often ask agencies and learners and other stakeholders like, number one, what is working? Number two, what is missing? And number three, how do you know? What's working, what's missing, and how do you know? And often that last question, the how do you know, means that there has to be data that someone's measured that can demonstrate what's working and what's missing. But without data, it's really hard to make a case for what's working and what's missing. And so I think having data to inform our conclusions is critical. So let's talk about those social determinants of health. Because if you take away nothing else from this talk, I want you to realize that the social determinants of health, and I don't know that I love that phrase to begin with, but the so-called social determinants of health are really what stand in the way of this country and frankly in most communities in this country from having better health outcomes. So number one is racism. It is probably the original sin for the United States and many other countries, but certainly in the United States, that racism has played such a huge role in the founding of our nation, in the way laws were written initially, and the way laws were developed, even to this day, but certainly in the early 1900s, late 1800s, so many laws were written that codified racism. And I'm bringing up an example here of one that I think is among the bigger examples of structural racism. It's the law that made marijuana illegal. And obviously we're now dealing with the opposite. We're dealing with legalizing marijuana. But in the 1920s, marijuana, first of all, was called marijuana for very deliberate reasons. There's no reason it had to be called marijuana, but marijuana is a Spanish, is a word that comes from the Spanish language, and it was chosen to marginalize people from Mexico and South America and Central America who were using marijuana for whatever reason. This was essentially a way of ostracizing people who were not white, people who were different, people who came from, across the southern border. You might find it somewhat ironic that we are having this debate all over again. But be that as it may, marijuana was called marijuana instead of cannabis or THC, which is what it probably should have been called and what we should be calling it now. But it was called that way to marginalize people who were using it, and that tended not to be people of majority status. And that was not the Irish and Germans that were using marijuana. And so all the laws that came from that, including the Drug Enforcement Agency Act of 1974, I want to say, made drugs criminal. And, marijuana right now is not criminal in many states. It's becoming legal. And unfortunately, that set up a long history of criminalizing people of color. And so when you look at the vast majority of people who are incarcerated in the United States, and we have the highest number per capita in the world of people who are incarcerated, is disproportionately more people who are people of color. Now, somebody will often say, well, there are more people who are white in jail than there are black. And yes, that is true because there are more white people than black people. But when you look at the rates, which is the only way you should be comparing anything, the rate, when you divide it by the total number of the population, the rate of people who are incarcerated is far more disproportionate to favoring people of color. So, but that's often a way that people will try to turn the debate around, but you never compare actual numbers. You always want to compare rates. Poverty. Poverty is something that happens in every country, and poverty is a major problem in the United States. And so what I'm showing to you here is the rate of poverty in Monroe County, which is among the more extreme counties in New York State, at least, in terms of poverty. We have a high concentration of childhood poverty in Rochester, New York, and none of us is proud of that. But when you couple poverty with being a minority, either Black or Latino in this case, in Rochester, that makes for a bad formula in terms of health outcomes. And the final thing I'm going to add, which I didn't really add until recently, is what I'm calling science rejection. And we saw this very acutely during COVID. People who would choose very actively to make the wrong decision, even when given facts and advice from credible sources. So, for example, the COVID vaccine, people who died from COVID were typically people who were not vaccinated. Much more people who did not take the vaccine ended up dying as compared to those who did on a comparison when you look at rates, not total numbers, but rates. And then you had all the misinformation that happened online, in social media, and even in the mainstream media that was glorifying things like hydroxychloroquine and ivermectin and all of these things that are not based in evidence whatsoever. We even had a president who said at one point that people should drink bleach. And people did that. And people not only took that as valid information, but then used it as a way of discrediting mainstream medicine. And we have to find a way to undo that, frankly, because it's only a matter of time before we have another epidemic of some sort. I don't think we're going to have a global pandemic anytime soon, but I do think that it's possible many communities, and some already have, are starting to see outbreaks of measles and other infectious diseases that could be prevented with vaccines. And to the extent that communities are foregoing vaccines, they are actually putting the health of their community at pretty serious risk. So in Monroe County, almost 4 years ago to the day, I announced the first case of coronavirus 19 in Monroe County, and we had the biggest press conference I would ever have to speak to on that day. And it was probably, yeah, I guess what I would say is that it shouldn't have to take a global pandemic to get people to listen to public health. So this was an emergency, a global emergency. I get it. Everybody was listening. But, the reality is that, most people don't think about public health unless it's a crisis. Here's proof. If science was to speak, this would be all that we needed. This shows hospitalizations among people who are not vaccinated in blue and vaccinated in red. Hospitalizations due to COVID-19. And no matter when you look in the pandemic, people who are hospitalized were much more likely to be not vaccinated compared to those who were vaccinated. And if it should have been that easy, right? If this was any other issue that wasn't polarized, all we would have to do is show something this basic, and people will just listen and do the right thing. If we had data like this that showed that seatbelts work, is there anybody who would take their seatbelt off? And the answer is probably not. But the reality is that it got so polarized in almost every state in the country that we had disproportionate death due to COVID because of vaccine or not. So we've learned a lot, hopefully, from COVID. We've learned that health equity is a problem. Health disparities that we were talking about before happened again with COVID cases in terms of the vaccination, in terms of the outcomes. We didn't have access to data around gender. So non-binary gender is not something that most hospital systems or healthcare systems keep track of. We didn't even have race ethnicity data in the beginning of the pandemic. So like I said, if you can't measure it, how do you know you're improving it? And, we were not able to get race and ethnicity for a number of reasons. Nursing homes bore the brunt of mortality in many communities, especially in the first 6 months of the pandemic, which was obviously before we had a vaccine. And the reason for that is because nursing home residents tend to be older and have more medical conditions, but also because the people who work in nursing homes are disproportionately, or for whatever reason, likely to be African American and or younger. Okay, so in Monroe County, as is the case in many other counties in the country, younger Black women tended to be the people who had the CNA title and worked in nursing homes. So, why is that a problem? Well, it's not a problem yet, except when you look at the pay for that job, it's quite low. It often doesn't have benefits. And so many of these people would work in multiple nursing homes at one time in order to make ends meet and pay the bills. So you think about it, you've got one person who's working in 3 different nursing homes during a global pandemic when we didn't have a vaccine and we barely even understood the role of masks and face shields. That's the reason why nursing homes bore the brunt of the pandemic in the early months, is because we were literally spreading it between nursing home to nursing home. And that's all because of structural problems in terms of pay gaps and pay equity that lived long before COVID. And frankly, it's an example of structural racism that we had women disproportionately younger and Black working in perhaps the most vulnerable healthcare settings that any community has. We don't do a very good job sharing data. We didn't even get adult immunization records during COVID. Like we couldn't figure out who was getting the shot in New York before they came to Rochester, New York. We learned a lot about preparedness. We learned the real importance of communication, especially around communicating about things that are scary. So, I would take the podium in March of 2020 and April of 2020. Everybody listened because everybody was a little scared. But come May, June, July, and beyond, a lot of people said, you know, I don't want to listen to authorities anymore. I'm going to get my information from Facebook. And so we did not do a good job communicating with all of those parts of our community because a lot of people had given up for whatever reason, and we can get into it. But I think one of those big reasons is fear. People don't like to hear scary stuff. And, as much as I wanted to be reassuring, I also didn't want to be misleading. And so I was very comfortable saying, I don't know. We just don't know. Nobody knows. Nobody knows when the vaccine for COVID will be coming out, I would often say in November and December of 2020. And then there's the whole issue around rejection of science. That is a major, major problem. This is my only slide on guns. Guns are a very divisive issue in the United States, and they do not have to be. So on any given day in the United States, suicide is probably the most underreported form of gun homicide. On any given day in the United States, we lose about 59 people to gun suicide. People who die by suicide using a gun is roughly 59 every day in the United States. Pretty consistently so. 59 people in one day from suicide. That's the same number of people that we lost in the Las Vegas mass shooting. So we have a Las Vegas mass shooting every day due to gun suicide every day in the United States. And when you think about who those people are who are dying by suicide with a gun, vast majority of them are men. And I think around 18 or 15% of them are veterans. So when you think about how divisive the gun control or gun safety debate has gotten in the United States, if you simply say that suicide by itself is a public health epidemic that disproportionately affects men and veterans, I think you'd get a very different reaction from a lot of the people who typically think that gun control is unnecessary. We have the largest number of guns per capita than any other country on the planet, and we have the highest number of gun homicides per capita of any other country on the planet. To say that those two things is not connected is probably unfounded. Now, we aren't able to study it very well because federal laws prevent us from studying it very thoroughly. But anybody who sees those two graphs, although you can't ever say, that association implies causation, we've got, centuries worth of data at this point showing that there is no real other reason to explain the two things other than that the number of guns is highly correlated and probably causal to the number of deaths. Overdose crisis. So last bunch of slides, I'm going to talk about the overdose problem and where it came from in the United States. So as I said before, it's a uniquely American problem. There isn't another country in the world that has an overdose epidemic like we do. And so you ask yourself, why does the United States have an overdose epidemic and other countries don't? And the reason for that is largely from the pharmaceutical industry. And the pharmaceutical industry in the late 1990s was often citing one paper as evidence that addiction was rare among people who were treated with narcotic pain medications. And that evidence is not even a full paper. It's just a letter to the editor of the New England Journal in 1980. So this is barely evidence. This is not evidence. When any of you who've done any kind of scientific training know that this is not a scientific paper. This is a letter to the editor with 2 references and not a study in any way that's rigorous. But the title right there is enough for industry reps to mislead people in our field, doctors, nurses, hospitals, and the like, into thinking that you don't get addicted when you take morphine or oxycodone. And we obviously know that that's not true. That is totally false. But this one paper drove a lot of the shifting beliefs about pain and how you treat it, all the way to the late 1990s, early 2000s. This is from my orientation packet when I moved to Rochester, where they talked about pain is the fifth vital sign. So you ask about, you measure a heart rate and blood pressure and pulse ox and so forth, temperature. And the fifth vital sign is your pain score. And the implication there was that pain was always meant to be zero, that you had to treat pain as best as you can. And, lots of hospitals gave out incentives, gave bonus pay if your average pain score was better. Well, of course, the way to make pain go away, if you have it, obviously preventing it's the best, is to give somebody pain medications to make it go away. And so when you look at the prescribing of pain medications in the United States, it went through the roof in the late 2010s, 2000s, all the way until roughly 2011, 12, 13, when we started to see things plateau. That's when we started to realize that people were getting addicted to prescription opioid medications. Now, if you look at the death toll from opioids, it didn't really pick up until 2013 and 2014. And the reason for that is because most prescription pain medications are difficult to obtain because you have to get a prescription from them. And we started to really clamp down on overprescribing of opioids, even though it was beginning to be a big problem in the 2008s and 9s and 10s. We started to decrease the amount of overprescribing that we did, but we already had a lot of people who are addicted to opioids. So when you take away their prescription opioids, they go to the streets to find other opioids. And that came in the form of heroin, which is that yellow line there. And then most recently, and still true to this day, is that dark black line, which is fentanyl. So fentanyl is far more potent than heroin. To give you a comparison of the amount of fentanyl it takes to kill a human being, it's shown in the little vial there on the right. And the amount of heroin necessary to kill a human being is in the vial there on the left. And when you put that highly potent stuff, fentanyl, and put it into street drugs in whatever form, that's what explains the huge increase in mortality from overdoses. And that's literally what's driving the overdose epidemic even till this day. So this is data in Monroe County to this day. Our data looks very similar to other counties in the state and in the country, where things got a little bit better before the pandemic, but then when the pandemic struck, numbers started going in the wrong direction again. So these are all the issues. This is just a snapshot of all the issues that impact health and public health. And I will argue that it isn't just hospitals and healthcare. So with that, I'm going to stop sharing and take any questions.
Okay, guys, go ahead and ask your questions now. This is the time to do that. Feel free to type it in the chat or unmute yourself. Anything is fine.
Well, just questions here. Anti-vaccine is not new. Why do you think it still remains until these days? Do you think anti-vaccine even will ever get improved in the future? That's a hard one. That's a really hard one. I wish I could say that it was going to get better. Anti-vaccine is not new. You're right. But I do think it got worse during the pandemic. For those of you who are interested, there is a book called Apollo's Arrow, written by Dr. Nicholas Christakis, who was one of my mentors at the University of Chicago. He wrote this book, Cupid's Arrow, about pandemics before the COVID pandemic. Obviously, he didn't know, and nobody knew that we were about to enter a global pandemic. And in that book, he talks about what characterizes a global pandemic. And one of the things that's mandatory is that things become politicized. And so insofar as science becomes politicized, we will always have an anti-vaccine movement. And science should not be politicized. Interpretations of scientific data should be left to scientists. And when we have non-scientists trying to interpret scientific data, it would be like a non-mechanic trying to fix your car. You wouldn't do that, right? You wouldn't trust a non-mechanic to take your car apart and put it back together again and you get behind the wheel. right? But somehow, you know, along the way, we've made it somehow acceptable that anybody who's got a keyboard and a Facebook account can become a scientific expert. And we've got political leaders who, for whatever reason, want to, well, whatever reason, the reasons because they want to get votes. So they pander to these populations, peddling non-science as truth. And so that perpetuates a cycle of anti-science. And so the anti-vaccine movement really is about anti-science. And what is anti-science, I think is a very complicated question. I think that science is a language that is a privileged language. People who are trained in science have to go through training to know how to talk the language of science. And science, for those of us who are in it, is inherently about uncertainty, right? So when we think about science, we are comfortable with uncertainty because we talk about statistics and p-values and all the things that make up uncertainty in science, and we have ways of quantifying that and feeling comfortable with it. But if you're not versed in the language of science, um, uncertainty is very disconcerting. And when science is quote unquote wrong, scientists say we need to redesign our experiments and try to understand that better. Non-scientists say, well, then science must be phony. And I'm not going to believe science. I'm going to believe some schmuck on Facebook who says that they know what they're talking about. So, how people handle and assimilate information, I think is fundamentally how we are going to get out of the anti-vaccine movement. The anti-vaccine movement is really about anti-science, right? So there are people who would pick hydroxychloroquine and ivermectin far more likely over Paxlovid for the treatment of COVID, even though there is no evidence to support hydroxychloroquine or ivermectin for the treatment of COVID. They would pick those treatments over Paxlovid. And if you look at who those people are, they're people who disproportionately obtain their news from Fox News, Newsmax, and Donald Trump. And there was a paper published in JAMA last year that studied that. And that's reality. And I'm not saying that to alienate those people. I'm saying that to say that we've got to find a way to reach those people and rebuild trust with those people, because those are the people who are going to get sick and end up in our hospitals if they don't believe in science. What about opioids? It's also not new. Why do you think it's still an issue today? Um, we never really got on top of the drug war. And in truth, drug war was never the right idea in the first place. So in the 1980s, when I was younger, when all of us were younger, I suppose, we waged this war on drugs. And unfortunately, the war on drugs became a war on the people who use drugs, not on the drugs themselves. So there was a lot of alienating, marginalizing people who use drugs. And this is not unlike what happened in the 1920s with marijuana. Marijuana wasn't the enemy because, when people were using marijuana, they didn't confiscate the marijuana, they incarcerated the person. Oh, and they took away the marijuana, fine. But they didn't look at addiction as a human illness. But the reality is that drug use is an addiction. It's an addiction is a scientific phenomenon that happens in our bodies. And you can be addicted to drugs or alcohol, which is a drug, or gambling, or sex, or video games, or you name it. Anything that causes dopamine release in your brain can trigger addiction. And we did not understand at the time, or were unwilling to understand at the time, that addiction was actually a medical illness. And it's not even a mental health illness. It's actually a medical illness. Depression is a medical illness. It affects our mental health, of course, but we need to think of all of these as medical illnesses, because then we, I think, stand a chance of getting rid of the stigma and the bias and all the things that go along with mental illness and drug use, right? So there's a lot of stigmatization around mental health, because somehow if you have depression, you must not be, whatever. And the reality is that having depression should be no different than having high blood pressure from the standpoint of you're somebody who has an illness and would benefit from treatment, right? We shouldn't be judging people whether they have cancer or drug use or drug abuse or what have you. And so, we haven't done a very good job of humanizing people who use drugs. We tend to, marginalize them. We tend to think that they've made bad choices in life. We tend to make all sorts of assumptions about people who use drugs. And I think the reality is that really anybody can fall victim to using drugs in a addictive way. Um, so is it right to say opioids is partly political? I mean, it's no more political than diabetes or anything else. I think what I think what makes opioids different is the bias that has evolved in our society around the people who use drugs. And to what extent politics drives that misperception, that might be what you're getting at. So yeah, I guess so. Um, but I think at the end of the day, when it comes to the drug uh, epidemic in the United States, the addiction, the overdose epidemic, number one is we have to find a way to humanize people who use drugs. When we get to the point where, you see GoFundMe accounts for people who are using drugs in the same way that we see GoFundMe, pages for people who have cancer, I think that'll be the day that, we've arrived at a place where we can humanize people who use drugs because they're humans, they're people like you and me. They're struggling with illnesses probably like you and me, right? And they have families like you and me. They may not have healthy relationships, and when you think about what causes drug abuse, it's social determinants of health. It's trauma, it's poverty and racism. And when you look in most communities, what causes early use and abuse and misuse of drugs, it's highly correlated with the presence of trauma, whether that's, having grown up in poverty, having only one parent in the household, having a parent with mental illness, having a parent who was incarcerated, having witnessed violence in your childhood. All those things are what predict drug misuse. Um, and most of those things are highly concentrated in communities that have been affected by racism and poverty throughout the generations. So, ultimately, to eliminate addiction, we've got to prevent it. And the way we prevent it is by addressing those social determinants of health that put people at a higher risk for having addiction in the first place. Thank you for a presentation. You're welcome. Curious to hear about more possible avenues for reducing opioid deaths and addiction. The hospital I work at just introduced a pre-hospital. Good. Suboxone. Yeah, good, good. Pre-hospital Suboxone. Yeah. So a lot of communities are doing that in New York State. I don't know where you're from, but EMS services in New York State, a lot of states are beginning to do inductions with Suboxone before somebody comes to the hospital and potentially instead of coming to the hospital. I think there's a lot of promise in that. The challenges around that is that there's still a lot of stigma and there's still a lot of misunderstanding about Suboxone. Even among my colleagues in medicine, not until 3 or 4 years ago was it possible for anybody to prescribe Suboxone. We used to have to go through this huge training to be able to prescribe Suboxone. And the reality is Suboxone comes in three strengths, small, medium, large, basically. And, it's not very hard to use Suboxone, but yet we had to go through this 8-hour class to use Suboxone, to prescribe Suboxone. Which made it feel a lot more complicated when it really wasn't. Anybody who prescribes insulin will tell you it's far more complicated to prescribe insulin than it is to prescribe Suboxone. And yet we don't have to go through an 8-hour class to be able to prescribe Suboxone. So there's a lot of bias that we're still trying to get rid of. And a lot of that bias isn't in the public, it's within the medical establishment. So that's something we got to change through policy. Earlier you mentioned that if we could show the data, such as the amount of unvaccinated versus vaccinated. Yep. Do you think we need better ways to educate? Yes, we need better ways to educate. I think that the assumption, though, that graphs and numbers and data, the assumption that that is what will change minds is false, because there is no shortage of data. There is no shortage of technical pictures that make our point. Where I think we fall short as the scientific community is in assuming that data changes hearts. The reality is that data changes minds, but stories are what change the heart. And when you think of how the media works, whenever possible, the media will try to make a story out of something. They'll want to hear from an affected person who was somehow impacted by whatever it is they're trying to highlight. They don't typically just show a bar graph or a pie chart, right? Because most people don't just think in that way. And even if it changes your mind for a little bit, All it takes is competing data, and we know there are always going to be competing data to change your mind back. But when you hear stories, and more importantly, when you're affected by something, that's what changes hearts. And so somehow we need to not just rely on data and charts and graphs to educate the public, but we have to find a way to connect with people. And the way we connect with people is through stories in ways that are culturally sensitive, that are appropriate for our audience, that are told not just by health experts and experts in general, but by everyday people, right? Because it's those conversations that you have around the dinner table with your crazy Uncle Pat, who won't listen to science. But if your Uncle Pat knows somebody at work or at church or at school who's been impacted by something, they're far more likely to listen to whatever it is you're trying to say. And it's, and I'm guilty of it too. We tend to marginalize and dismiss people are who don't listen to us. Well, why would they? If they didn't have the access to training, education, science, and this is, people of all colors, why would they necessarily believe what I have to say? Because science by itself is a technical language. It's a foreign language. How does that person not know that I'm trying to pull one over on them? Right? So, we have to find a way of getting out of our ivory tower and our, that because I know science and I've gotten a bunch of advanced degrees and I can speak science, doesn't mean that people need to listen to me. I've got to find a way to make my message accessible to people, even who don't have the scientific background. And that's the challenge. It's not just about, you know, education isn't necessarily learning. Education is a process, but learning is the goal, right? What else is in here? These are good questions. Keep them coming. What else? I don't see anything else. Any other questions?
Are there any more questions left, guys? If not, let us know in the chat so we can wrap things up. Okay, we got one question. What advice would you give to someone considering getting an MPH?
MPH, Masters in Public Health. What advice would I have? Well, first of all, I'll say there's no perfect time to get a master's in public health. There's no right time, there's no wrong time. Anytime you get it, I think it will give you added exposure, comfort with the language of public health. Public health programs, though, have changed quite a bit since I went through my public health training. When I went through public health school, it was very general. And there weren't that many public health schools at the time, but now there are so many public health schools and so much more to the science of public health that I think, one needs to think, do they want to have broad education for a particular reason, or do you want to have very specific education for a particular reason? So I can think, for example, if you're earlier in your career, like I was, when I got my MPH, I was much more interested in a broad sort of survey of public health. If I were to go back and get a public health degree now, it would probably be in epidemiology. And I would want to know even better than I do know the science of epidemiology. So it really depends on what stage of your career you're in and why you want to get an MPH. I also think that it's not mandatory that you get an MPH in order to work in public health, though I will say that it's very helpful. There are a lot of things that I learned in public health school even 25 years ago that I don't think I would have learned anywhere else. And I certainly wouldn't have had the classmates that I had in public health school in any other place. When I went to business school to get my master's in business, I was a very different student population than even medical school, let alone public health school. So, school isn't just about the books and the classes and the tests. It's also about the people you go to school with. And, that's why you go to a good school, to meet people who are serious about learning and serious about the study. And that's why I think online classes are tough sometimes, because I worry that you don't get to see and have that level of engagement with classmates that you would in classes. And yes, I get that it's more inconvenient to go to a class and potentially more boring, but you don't get to meet people online in the same way. At least is my bias. So I don't think I don't think it's a mandatory to get an MPH, nor do I think it's a mandatory to have a master's in business in order to do business. But, when I went to business school, I learned about finance and investments and economics and marketing and communications. And I would never have learned that in any other place. So I think it's a starting step, but it's not the end all be all. How was my experience as a medical director? My experience as a medical director, I was medical director of Highland Family Medicine, which is a primary care clinic where we train medical students and residents and fellows. Um, my experience, I think, as a medical director was frustrating, not from the day-to-day of the job, but really more from the standpoint of the system that we were trying to operate in as a practice. And that's what gave me my, instincts as a public health person is thinking through, there's so much more that we want to do to improve health, and so little of it can be impacted from the four walls of a clinic. So anything that I did from a medical director policy standpoint was unlikely to impact gun violence and suicide and, accidents and injuries and car accidents and all the things that actually lead to premature death, right? So medical practice is by definition about treatment. We like to think that it's about prevention, but the reality is it really shouldn't be about prevention because it's the most expensive part of our healthcare system. And if we're putting doctors and nurses in hospitals in charge of prevention, and we know that we need more of it, and then we conclude, well, we need more hospitals and doctors and nurses, then we're going to make the most expensive healthcare system on the planet even more expensive, right? So we've got to find a way to do prevention in a more cost-effective way. And you don't need doctors and nurses and hospitals all the time to do prevention. You can do a lot of that in the community, and churches and schools and pharmacies and dentist offices can do it much more effectively than and cost effectively than hospitals, clinics, doctors, and nurses. So it was frustrating to me. It's a great experience, don't get me wrong, but it was also frustrating to me that, what I really wanted to do was to see an improvement in public health. And I quickly realized that I wasn't going to be able to do it because of anything I did in a medical office, right? So in medical office, you improve, the practice volume and the quality of our care and all those things. And that's very important, right? We want to see people with high blood pressure have lower blood pressure. We want to see people with diabetes have lower blood sugar, right? Those are all important things. But the cat's out of the bag. People already have high blood pressure and diabetes, right? So if you really want to see an improvement in life expectancy, the better approach will be to prevent high blood pressure and diabetes. And we don't do that from clinics. We don't do that in hospitals, right? We're not set up to do prevention. And we certainly can't do it, seeing patients one by one in a day, right? So in a given day, I could see 20 patients. If you do the math, it's going to take us decades to see everybody once. Whereas if you have a public health program and you have a very successful public service announcement program, you can reach thousands and hundreds of thousands of people much more effectively with a message that makes more sense, right? So that's how we got all of our improvements in tobacco use throughout the late 1900s. It wasn't through medicine. It was through public service announcement. It was through publicity campaigns. It was through changes in policy that made it harder and less desirable for people to pick up a cigarette in the first place. And that's how we had public health wins. That's how we won the war against nicotine and tobacco. Now we're losing it again because of vaping. We're seeing increases in tobacco use that we haven't seen in decades. And that the reason for that is because nicotine is in most vapes. And once you're addicted to nicotine, it's whether it's fentanyl, nicotine, alcohol, gambling, whatever, it's an addiction. And the only way to get more nicotine is to reach for a cigarette. So that's no surprise, unfortunately. What I consider politics in the future. I just left the world of politics, so I'm not interested in it right now. I was the commissioner of public health for Monroe County for 8 years, and politics is how you make policy. That's the period. Period. If you want to look at changing policies, you got to go into politics. Now, not all policies that matter are laws. Some of them are regulations that happen at various other levels, like schools and businesses and towns and villages. So there's smaller levels of politics. It doesn't always have to be elected office, but the people who make decisions in the world are elected, and elected people have power. And when we see poor turnouts among just marginalized communities, I say to them, you're giving your power to somebody else if you don't vote. And I want to see more people from every community vote more. But unfortunately, we see a lot of marginalized people, people of color, people of limited means, they don't show up to vote nearly as much. And, we have a gerrymandered, weird electoral college system that doesn't help. But the reality is, we need more people voting to make changes in the world. I may go into politics someday. Right now, I want a break. But I think it's where things happen. I was lobbying in Albany, New York, 2 weeks ago for changes in the budget for New York State, and it's how you get things done. When you talk to a legislative director who's often in their 20s or early 30s, they're not experts, so they listen to me as an expert in a particular area, and then they take that to their lawmaker, and that's how they make a law, right? Lawmakers are expected to know everything about everything, and that's impossible. So it really is about how do you influence them and tell a story, right? So when I'm advocating in any governmental setting, I don't necessarily just bring numbers. I bring stories of people that I take care of as a doctor, or stories that people tell me from my world as a public health commissioner. I mean, that's what changes hearts. And if you're changing policy, the way you change the hearts of a politician is by telling them a story. I will do great. Maybe. I'll take a break for now, though. Thank you all. I've really enjoyed our time together. I think you guys will have my email address somewhere. Don't hesitate to reach out to me. I'm on LinkedIn, Dr. Mike Mendoza. Twitter, or whatever they call it now, is also the same, Dr. Mike Mendoza. I'm always happy to be in touch.
Okay, perfect. That's great. I'm going to go over a quick closing presentation just to kind of wrap things up. Thank you, Dr. Mendoza, for giving this really insightful presentation. I loved listening through in the background and hearing all of the questions and answers.
Thanks. You're welcome.
Let me just share my screen real quick. Okay, so let's reflect on what brought you guys to the session today, what 3 major takeaways you got from this session, and what you would like to learn more about. So you can type your answers in the chat. And if you would like some recognition, please submit your thoughts on today's session on our blog submissions page on our website. If you're interested in being part of our student volunteer or team member team, please be sure to follow those links or visit our website. And if you can, please donate to help our program stay free and accessible to everyone, as we do run solely off of the time and donation of our volunteers. And make sure that you earn a digital certificate for attending by taking our post-shadowing assessment. You can do this by visiting our professionals course page at prealshadowing.com and sign up for free. And this quiz is going to be a simple 10-question multiple choice based on the presentation today, and you have 2 chances to pass with a 70% or higher for verification of your virtual shadowing hours. Quizzes are open indefinitely for your convenience. Oh, sorry. And if you missed any part of our session, be sure to visit our YouTube channel at Shadowing and catch our sessions every week. Thank you guys so much. We'll see you next time.